Today we discuss cholestasis in neonates and children. The objective of this lecture is highlighting the definition, etiology, management, prognosis of cholestasis. The definition of cholestasis always involves obstruction of the bile flow. It might be an earlier step like impaired secretion of the bile produced by the hepatocytes, or due to obstruction of the bile flow through the intra or extrahepatic bile ducts. Once bile cannot flow from the hepatocytes to the duodenum and there is interruption of the excretion of bile, we get the clinical picture of cholestasis. Mind you, it is defined as 20% direct bilirubin in the total bilirubin of more than 1.3 milligram percent. That means that this is applicable to a total bilirubin of more than 1.3. So what is this obstructed bile? What is this bile? Bile is a product of hepatocytes. Gallbladder bile has 97% water. It contains 0.7% bile salts, 0.2% bilirubin. It contains fats, cholesterol, fatty acids, and lecithin, and it contains 200 milliequivalent per liter inorganic salts. How much bile do we produce daily? Something between 500 and 1000 cc's per day. And once they reach the gallbladder, a lot of the water is reabsorbed, hence bile is concentrated 20 times in the gallbladder, and most of the bile salts are recycled. What is the main constituent of bile? It is bilirubin. It gives bile the yellow color. What is bilirubin? Bilirubin is the degradation product of heme, of the senescent RBCs, and it cannot be degraded beyond its state, so it has to be conjugated and excreted as bilirubin, and it's a detoxification product of heme. What else is detoxified? And why do we need to do this detoxification story? Because as we all can see, all the cosmos is made of 118 elements. All the elements bind ionically or covalently. Trees, universe, cats, even doctors are made of only 118 elements, and these elements bind in a covalent or ionic bonds. And hence, all creatures have specific composition and concentration of elements. The liver has to do the breakdown, recycling, detoxification, and excretion of all elements that we don't need, that would disrupt the composition and concentration of our bodies. So what does this bile do? It rids our bodies of the detoxified material, of the covalent bound chemicals and toxins, just to maintain our composition and concentration, and it emulsifies fat. What is emulsification of fat? In the presence of bile acids and pancreatic lipase. Hence, lipids will be digested into very small particles, and they will be readily absorbed, thus helping absorption of fats and fat-soluble vitamins like vitamin E, D, and E and K. So we said that cholestasis is defined by failure of flow of bile from the hepatocytes. How does the bile leave the hepatocyte? Actually, every hepatocyte has actin and myosin that is responsible for expulsion of the bile, which it has already produced as a vesicle. And the expelled bile will reach the gallbladder, and as we said, it will be concentrated by reabsorption of water in the gallbladder. We have to note that There is no direct continuation between every hepatocyte and the bile ductule, but rather every hepatocyte has to expel the bile. And we have to note that the bile ductules are lined by cholangiocytes, and these cholangiocytes they excrete sodium, water and sodium bicarbonate, but this water that is all the time being poured in the bile ductule aims to less to make the concentration of bile less viscid, so that it will not get it will not cause obstruction of the bile ductules, so that bile will not cause obstruction of the bile ductules. But please be very aware that any disruption of structure or function, it will result in obstruction of the bile flow. So what are the effects of retaining bile? Bile is washed away through the central vein into the circulation, and the bile salts and bile acids and the bilirubin would be elevated into the subject. He will have or she will have bradycardia, itching, jaundice, change of color of urine and stools. They will get the clinical picture of deficiencies of vitamin A, D, and E and K, and eventually they'll get a picture of biliary cirrhosis. What are the causes of retaining bile? It's either intrahepatic or extrahepatic. Intrahepatic is a hepatitis or paucity, that's a decrease of intrahepatic biliary radicals in the portal tracts, and this is something that needs to be diagnosed by a liver biopsy. Extrahepatic, it can be an obstruction of the common bile duct or common hepatic duct or right or left biliary radical. It can be due to compression, outward compression like lymph nodes, or malignancy like cancer head of pancreas. What are the causes of retaining bile? Children can get a structural defect or a functional metabolic defect. It can be acquired in like inflammatory, infection, immune diseases. It can be drug-induced trauma or malignancy. And this acquired condition, irrespective of the etiology, would result in a structure or a functional defect. You are all advised to read about Kotb disease, biliary atresia. It is defined as congenital aflatoxicosis in children with glutathione S-transferase M1 deficiency. This is a condition where the mother is heterozygous for GST-M1, and the baby, before being born, will be protected by her placenta. If mom before delivery gets to eat food which is contaminated by aflatoxin B1, and the mom is homozygous for GST-M1 deficiency, then she will not suffer and will not have any phenotype. Baby is protected by her functioning placenta, detoxifying the aflatoxin. But once baby is delivered and the cord is milked, an amount of aflatoxin would reach the portal vein of the baby, and the baby will have the aflatoxins trapped in his liver, and baby will not be able to detoxify the aflatoxin loads. Moreover, the mom is detoxifying aflatoxin B1 and is transferring it into aflatoxin M1, which is being excreted in her breast milk. Baby will be feeding from his mom and from its mom, and it will receive an additional amount of aflatoxin. What happens then? What happens is that aflatoxins will cause inflammation of the walls of the common hepatic, cystic duct, gallbladder, common bile duct, of the major biliary radicals, major bile ducts. And after inflammation, it will end in adhesions, and we get the structural complication, which we call blearyatresia. Please note that because this is a drug-induced or an aflatoxin-induced cholangiopathy, we always have elevated gamma GT. What else? Please note that in children we get something called progressive familiar intrahepatic cholestasis, and we get also bile acid synthesis defects, not very common, but we come across them. Please note that in order to understand the bile acid synthesis defects, we have to go back a step. How does the liver detoxify drugs or chemicals? The first tier is through the cytochrome P450 family, and this is for ionization and rendering the chemical water soluble. The second tier is intended for the covalent or organically binding chemicals, and this glucuronization is the second tier. It occurs through glucuronyl transferase. The third tier is containing this detoxified material, which is not ionizable, into the multiple drug resistance protein. Please note that bile acids are the detoxification products of cholesterol. Children with PFIC or progressive familial intrahepatic cholestasis, we have three types. Type 1, we have a problem with the enterohepatic circulation. Type 2, there's a problem with the bile salt export pump defect. And type 3, it's a problem with multiple drug resistance proteins. The type 3, the children have elevated gamma GT, contrary to type 1 and 2. So what is the clinical picture of cholestasis? It's a clinical picture of the cause, of the cholestasis, of the functional status, and of complications. Clinical picture of the cause, you can find something like gallstones, cancer head of pancreas, drug-induced, like other diseases to which the patient received drugs like azithromycin or methotrexate or other related conditions that necessitated drug intake, and it resulted in drug-induced hepatitis, like other known diseases, anti-epileptic medications, etc. You can have associated immune disease like systemic lupus or other features of immune disease. You can have associated features of metabolic disease, galactosemia, tyrosinemia, etc. What's the clinical picture of hypertension? The child will have ascites, low limb edema, varices. The child can present by hematemesis, melena, or bleeding hemorrhoids. They will have arteriovenous shunting, splenomegaly, and hypersplenism. Cholestasis per se would cause jaundice, itching, change of color of urine and stools, bradycardia, liver cell failure. If the child gets liver cell failure on top of the cholestasis, he will have bleeding tendency, encephalopathy, hypoglycemia, growth failure, etc. So what's the management? Investigations and treatment. Of course, we have to investigate to know the cause, underlying cause. What is the status of the cholestasis, the functional status of the liver? We have to investigate and provide treatment of complications, and finally liver transplant. Please note the gamma GT, it's elevated in liver or bile duct disease. Glutathione is a detoxification enzyme. It is formed by glutamate, cysteine, and glycine, but mind you, this is we have to absorb or eat glutamate, cysteine, and glycine, and they are formed intracellularly. Kindly note that we can get a normal gamma GT in PFIC type 1 and 2, Rotor syndrome, and bile acid synthesis defect. It can be normal and high in Dobbin-Johnson and estrogen progesterone drug-induced hepatitis. It can be elevated in biliary atresia, bile duct disorders, PFIC3, drug-induced hepatitis, cardiovascular metabolic syndrome, and type 2 diabetes. Kindly note that Whenever we find AST and ALT elevated, this points to ruptured hepatocytes and not apoptotic hepatocytes. The enzyme 5-nucleotidase is also elevated in obstructive hepatobiliary disorders, um, and it may indicate cholestasis or destruction of liver cells, liver ischemia, liver tumor, and it is used as a marker of liver disease. What's the prognosis of cholestasis relies upon the cause, upon the extent of cholestasis, on the functional status of the liver, of the complications, of the structure of the hepatic lobule, whether it's lost or not. That's to say, if the child develops cirrhosis or not. Please take away this message. Never use ursodeoxycholic acid in cholestasis in children. First of all, because it's not licensed for use in children and it is contraindicated in Egypt, because in infants with neonatal hepatitis and extrahepatic biliary atresia, and also in those with paucity of intrahepatic biliary radicals, it compromises chances of cure. It reduces chances of resolution of cholestasis up to only 50%, while without ursodeoxycholic acid, cure is almost 75%. Please note that it increases chance of liver cell failure and death. Please also note that the complications with ursodeoxycholic acid results in liver cell failure, death. It induces paucity of vanishing of intrahepatic biliary radicals. It induces pneumonias and infection. It is not effective and not safe to use ursodeoxycholic acid in children. Please note that these results are almost always consistent with reduction. If you use ursodeoxycholic acid in cholestasis in infancy and childhood, you always get compromised chance of cure and resolution of cholestasis and elevated risk of liver cell failure and death. Please note that we do not use bile acids, ursodeoxycholic acid, when bile acid synthesis defects. It compromises the chance of cure as well. Please note that those who received ursodeoxycholic acid had worse outcome and more complications. Chance of cure decreased to less than third with the intake of ursodeoxycholic acid. Please do not use ursodeoxycholic acid in cholestasis, in neonatal or cholestasis or childhood cholestasis. Please do not use silymarin in cholestasis. It's interesting, however, that you can use spore-free honey in cholestasis, in neonates, and in pediatric cholestasis. It was a very interesting study at a master degree where children and neonates who used honey, spore-free honey, they had the highest chance of resolution of jaundice, and even compared to the control group. Is spore-free honey safe? Yes, honey is safe for children. No cases of infant botulism and flaccid paralysis were reported ever in Egypt. Botulism is a reportable disease in Egypt. Egypt reports flaccid paralysis for worldwide polio eradication. It was never reported in Egypt that we had a case of infant botulism at all or from honey. In Argentina, incidence of infant botulism is 2.2 per 100,000 live births. In the United States, it's 2.1 per 100,000 live births. In any case, we advise analysis of botulism of honey for botulinum spores in honey prior to its use in infants with cholestasis. PCR detection of botulism spores and toxins is currently available. We have to acknowledge that all the artwork illustrations were derived from Wikipedia. Well, I thank you for all your attendance. Please note that there are no facts, they are only interpretations. There's a huge horizon for change of medicine that you are capable of making. You can make the change. Thank you very much for your attendance.